Hello, everyone, and welcome to McGill Cares webcast series supporting family and informal caregivers. I'm Claire Webster, a former caregiver, certified dementia care consultant, and founder of McGill University's Dementia Education Program. I work with a dynamic team of leading healthcare professionals to oversee the program, who include Dr. José Moret from the Division of Geriatric Medicine and Dr. Serge Gauthier, Professor Emeritus, formerly of the McGill University Research Centre for Studies in Aging. These webcasts are made possible thanks to the generosity of our donors, and I would like to thank the Zeller Family Foundation for sponsoring today's webcast. So our topic today is end-of-life care in dementia. My guest is Dr. Catherine Ferrier. She is a family physician who works in the Division of Geriatric Medicine at the McGill University Health Centre, where her focus is on cognitive disorders and the assessment of decision-making capacity. She has a Certificate of Special Competence in Caring for the Elderly from the College of Family Physicians of Canada. She is also an assistant professor in the Department of Family Medicine at McGill University. Welcome to McGill Cares, Dr. Ferrier.
Thank you so much. It's a pleasure to be here.
Well, today is going to be a difficult topic, but an important one because we are going to be discussing end-of-life care in dementia, which is a reality that, everybody must face at some point. But also, it's a topic where not too many people have a proper understanding of what's coming up and how to prepare themselves. So I'm going to let you do a presentation to explain to everyone how they could best prepare themselves.
Thank you, Claire, for that introduction, and I'm very happy to be here. And as Claire mentioned, it's a bit of a tough topic, but it's an important one because we want to care for our elders with dementia throughout the course of their life, right up to the very end. And I'm going to try to give you a few clues on how we do that. So this is an outline of what I'm going to talk about, what to expect, goal concordant care, which I'll explain, briefly home versus nursing home, medical concerns that can come up, and then death and dying and grief at the end. So dementia is a chronic and a terminal disease, as I'm sure you all know already. It's not, we cannot cure it. It gets progressively worse, and we can slow the progression of symptoms to some degree, but we cannot stop it or reverse it. And people often live with it for many years. Eventually, people will die of their disease or its complications, unless they die of something else first, which is also very common. And this is similar to any other chronic organ system disease like heart, lung, kidney, etc. So as dementia progresses, we see two phenomena happening at the same time. One is cognitive and functional decline, and the other is increasing frailty, and I'll explain both. So cognitive, you're already familiar with, I'm sure, memory, language, orientation, recognition of people and objects, and then functional ability to care for oneself, to care for one's home, all of the things that we did naturally over life, we begin to lose those capacities. There's a researcher called Reisberg who several years ago developed a theory that he called Retrogenesis, which put in parallel the losses in, he was talking about Alzheimer's disease, which is one kind of dementia, but applies to a certain degree to all kinds of dementia. So he compared them to the development of skills from infancy to the end of childhood. So if we look here at the last stages of Alzheimer's disease, we're looking at middle childhood moving towards infancy. So from being losing the ability to perhaps choose one's clothing, then to go on to losing the ability to actually care for oneself, dress, wash, and so on, and goes on to difficulty with speaking and walking and sitting up and so on. So why does this matter? It matters to me because we don't ignore babies because they're weak and dependent, and people with dementia are fully human and retain their dignity to the end, and they should also be valued and treated with respect to the very end. And I would like this to always be the case, but unfortunately it's not always the case. And that's why I'm bringing in this reminder. The quote at the bottom is from Dr. Félix Pajot, who's a young geriatrician in Quebec City. He wrote a book about protecting people with dementia. And he wrote that the intrinsic value of a toddler who's incontinent, needs help to eat, dress, and wash is never questioned. The child is worthy of consideration and care, even if he's not yet acquired propriety, which we sometimes confuse with dignity. So what about the people who either never could do these things or who lose the ability to do these things as their dementia progresses. So the needs of a person with severe dementia are similar to those of a young child or an infant, depending what stage they're at. They require the same emotional care, the same physical care. They need touch. They need soothing speech. They need people that they're familiar with around them. They might scream if they can't have their needs met in any other way. They might withdraw if there's no contact with people. But if we neglect a healthy infant, they cry out. If we continue to ignore them, they withdraw. So the needs of a person with severe dementia include support for all of the things that they can't do for themselves anymore, but also to consider the needs that they might not be able to express. They're hungry, thirsty, hot or cold, have pain, have any other kind of discomfort. As anybody's done with a baby or a young child, you have to foresee all those things, keep them warm and fed and hydrated and so on. Frailty is another phenomenon that, as I mentioned, is going on at the same time. This is something that's well recognized in geriatrics, although it's a bit hard to pin down, as you will see. Basically, it's vulnerability to poor recovery after a stressor event. So that might be an illness, a fall, hospitalization. You don't bounce back the way you did before. So people of the same age might have different vulnerability to these outcomes, which could go as far as being death or institutionalization or just not getting better as quickly from a medical or surgical intervention, or having something else go wrong as a result of that intervention. The picture on the left is my mother after a tennis game just before her 90th birthday. So she would not be considered frail for her age. And the others are stock pictures of frail older people who I'm sure you would recognize. And this is a consequence of cumulative decline in physiologic symptoms during a lifetime. So all of our organ systems are losing function little by little over time, and it starts to catch up with us when we get frail. So an apparently small event can cause a striking and disproportionate change in health state. So you might have a bladder infection, and instead of just getting over it in 3 days, as a younger person would, you become more dependent or less mobile, or start falling, or become delirious, and it could take time to recover, and you might not recover back to your previous state. And a treatment that would be beneficial in someone who's more robust could cause harm to someone who's frail. For example, over tightly controlling their blood pressure or their diabetes can make their blood pressure too low, or their blood sugar too low, can cause them to fall, can cause other kind of problems. Being in the hospital could make them confused, could lead to other medical complications. So we have to be more cautious in the way we care for people who are frail. To give you an idea of how we measure frailty, typically in medicine, when there are many ways of doing something, it's because there's no consensus about any one way. So some people try to measure frailty with blood tests or with muscle strength or with gait speed. This is one scale that has to do with function, although frailty and function are not the same thing. But as somebody becomes more frail, they also generally become more functionally dependent. So as you see, number 1, very fit, would be like my mother, and 9, terminally ill, would be somebody who's approaching death. These are the last stages of someone perhaps with severe dementia. So as you see, they, from the pictures and from the descriptions, they little by little become more dependent for everything until death approaches. So then the question is, do we treat people with all of the same medical interventions when they're older and frail and have dementia as we would when they're younger? And the answer is not necessarily, because it might not be good for them, and they might actually harm them. So it's good medicine and good ethics to limit treatment when the risks and the burdens might be actually greater than the benefits that we expect. People with dementia and frailty are at higher risk of adverse outcomes of everything we do in medicine. And this increases over time as the dementia and the frailty get worse. The risks and burdens increase and the benefits decrease. So we're always having to find how that balances in every specific situation. So palliative care, which was developed for cancer patients, is completely applicable to every life-limiting illness. We try to use a palliative approach with people with dementia as the end of life approaches. And this is not devaluing or abandoning the patient. It's accepting that we can no longer halt the natural course of their illness and treating them in a way that's best for them. This is not to say that our patients with dementia are never devalued or abandoned. Unfortunately, they can be, and often they are. The healthcare system goes very fast and doesn't always have time for the people that we care about. And that's why we always need to be there to advocate for them. But just the fact that someone's proposing to limit medical interventions is not a sign that they don't care about your mother or your father or your spouse. It could be because it really, and it needs to be discussed. This is what is the best intervention for this person. So this brings us to the term, the concept of goal concordant care. And basically that means that our goals change over time and as our health status changes. So as our dementia progresses, as our frailty progresses, our goals are not the same. It might not be to get back to playing tennis. It might be something else, and it will change continuously. And that's why we're going to talk in a minute about advanced care planning. We can't just say, I would like this or I would not like this as far as healthcare treatments and expect that to be stable for the rest of our lives, because our needs will not be the same. So we need to, from our perspective, to perceive the people's needs over time, and to apply them for both the healthcare professionals and the family members. So what is their medical condition and what are the risks and potential benefits of the interventions that we're considering? And also what gives them comfort, what distresses them. And something that is not at all distressing to somebody who understands that this intervention is to improve their health can be very distressing to someone who doesn't understand at all why we're doing this to them. So that's why it's important to give authority to a proxy decision maker, what we usually call a mandatory in Quebec, someone who's authorized to decide in that person's name, so that they can decide in the moment and not just look at a list or a static statement of what somebody said years ago. So a couple of interventions that we might think about. One is cardiopulmonary resuscitation. That's the most extreme intervention that there is, really. So your heart stops and somebody pumps on your chest to try to get it started again. They put in intravenous lines. They put a tube in your lungs. That is very, very high tech. And we're not going to discuss it in detail, but briefly, in the people that we're concerned about today with advanced dementia and advanced frailty, the success rate of this approaches zero. It was really designed for people with young and relatively healthy hearts, perhaps into the 6th or 7th decade, but not for people whose hearts are failing because their whole body is failing. And so generally we do not recommend it, not because we don't think people are worth resuscitating, but because it likely will not work. It's very invasive, it's very aggressive. And even if the heart starts again, the person will be in very poor condition, will be in an ICU. And it's really not what we would wish for most of ourselves or our loved ones. Mechanical ventilation is one step down. And we do have a bit of time if the need arises to consider that. CPR, we have no time. Mechanical ventilation, it's still quite invasive, putting a tube into your lungs and having a machine make you breathe. So that if you have pneumonia and you can't breathe on your own, or you have some other lung disease and you can't breathe on your own, the consideration is always, is this a temporary measure until my lungs recover? Or do I expect to never be able to get off this machine? And so all of those things have to be taken into consideration in the moment. There's a clinic, there's a group of geriatricians at Dalhousie that developed something called palliative and therapeutic harmonization. It's a very interesting approach. I won't go into it in detail, but they have a clinic, they do research, they publish, and it's all about taking into account frailty as you decide about therapeutic measures as people's frailty progresses. And one of their main points is that advanced care planning, if it's not put into context, can really lead people to have false expectations. We can think that the ventilator is going to get them back to the way they were before, when that is very, very unlikely to be the case. And that could apply to many other interventions. And it's really a question of focusing on the big picture and trying to align people's expectations and their decisions with the likely benefits and burdens of the treatment that's being proposed. So advanced care planning, which is basically thinking and discussing about one's healthcare wishes for later in life, is a very, very good thing to be doing, but with caution in the sense that it has to be centered around possible eventual conditions. So it has to be centered around frailty. And I've said it before, and I'll say it again now, that a checklist is not usually a very good way of doing this because we don't know what condition we'll be in when the question arises. So a much better way of doing advanced care planning, which is what's recommended by most of the big organizations now, is to name a decision maker, talk with that decision maker, make sure they know your outlook on medical care, on intensity of medical care, and give them the authority to make decisions in the moment based on what they know about your goals, what they know about your condition at the time, your degree of frailty, and what the healthcare team tells them about the expected risks and benefits of the treatment being proposed. And minimize instructions on specific treatments. Really, the big exception being CPR, cardiopulmonary resuscitation, because as I mentioned, you can't decide on that at the moment that the need arises. It's too late. And usually the benefit is quite low for the people that we're talking about today. So there are some problems with texts that are commonly used. So the checklist version, I haven't seen that much. It's in the literature, mostly in the US, and I think that's problematic for reasons I've told you. But even here, sometimes I've seen texts inserted into people's protection mandates, for example, which is a document, a legal document with which you delegate healthcare decisions, with very ambiguous terminology. I'll show you an example in a moment, which can be very open to interpretation depending on who's reading it, what their perspective is. Is it a family member who loves you and knows you well? Or is it the doctor in the emergency room who is under a lot of pressure to move people through and might understand things in a way that's not at all what you want? Is it somebody in between? How will this be interpreted? And I'm a bit concerned about the fact that these are often inserted into mandates drawn up by notaries, and I don't think they're always discussed with a health professional before the person signs it, and they think they know what they're asking for, but do they? So here's an example that I've seen several times, so I imagine it's a standard, at least in certain milieus. So the idea of being opposed to heroic diagnostic measures that are superfluous given my condition, and as I've already said, there could be measures that are superfluous given your condition, but it's not immediately obvious what that means. It means taking into account who you are, your goals of care, your medical condition over the past few years, not just your medical condition right now, how you appear to the person who's seeing you perhaps for the first time, and does not even know what is superfluous given your condition, but might think they do. And so this kind of ambiguous terminology can be problematic, whether it's diagnostic measures, therapeutic measures. What is an irreversible condition? Does it mean that you won't get back to the way you were when you were 25 years old, or that you won't get back to the way you were before this illness, or that you won't get back to another level of autonomy, which is nevertheless reasonably good, even though it's not the same as you were before? What does irreversible mean? It's a very term that's open to broad interpretation. And then the last one, I'm opposed to any operation or treatment that could cause serious after effects or leave me in a vegetative state. Well, if it's likely to do that, nobody would recommend it. If it could, well, could mean 0.1 risk, or it could mean 99% risk. At what level of risk do you decide not to do that? So this again is very, very open to interpretation based on the person that's reading it. I personally think that these texts should be eliminated, and everyone who has anybody who could be a proxy decision maker, name that person and make sure that they understand your goals and are able to work with them as time goes on. This is a more useful instrument, I think. This is developed by the Quebec government. It's called the Levels of Care and CPR Decision Form. It's used in all healthcare institutions in Quebec. So this is the important part. Capacity, we won't discuss today, but the next box is levels of care. And it gives you 4 choices: level A, B, C, D. A is prolonged life with all necessary care. B, prolonged life with some limitations. C, ensure comfort as a priority over prolonging life. And D, ensure comfort without prolonging life. So A might be a healthy, middle-aged or young older adult who still thinks that everything is worth trying because they're basically in good health. B might be limitations because of certain health conditions or advanced age, but the limitations would be decided in the moment by the patient if they're able, or the proxy decision maker. C and as the end of life approaches, and D would be very close to the end of life when prolonging life is clearly no longer possible and comfort becomes a major priority. Then the next box about CPR, cardiopulmonary resuscitation, attempt or do not attempt. So that's a separate question. As I mentioned, attempt doesn't mean that you will succeed. In many cases, you will not succeed. And that's a decision that's separately. And for the most part, in people who have advanced dementia, I would recommend do not attempt because it will not succeed and it will only cause distress and harm to the patient. So another question briefly, where is the best place for caring people as their dementia advances? No single right answer is good for everyone. Considerations for care at home. The first is safety. Is the person living alone? Do they live with someone else? If they live alone, are they at risk of falling or wandering or not nourishing themselves adequately or taking their medications properly or leaving the stove on? If they live with someone else, does that person or if there's someone coming in the family, do they have the time, the energy, the health, the knowledge and skills to provide care for that person adequately? Do they have the support and rest that they need, which is absolutely essential? As the condition progresses, you'll need more and more outside help, whether it's from other family members, from the CLSC, from private agencies. That will increase with time. CLSC is free, but there are limits. Private is paid for, but there are basically no limits as long as you can pay for it. But if you really are approaching the end of life, you're hoping to die at home, then you're going to need medical and nursing support at home, which really means home palliative care. And that's not available in the public system everywhere. Some CLSCs have unbelievably good home palliative care teams. Others do not. Others have none at all. So that it's important to know. And we always need a backup plan. What if the patient's condition changes suddenly? Suddenly they can't walk or something else, and the person cannot provide care anymore? What if the caregiver gets sick or the caregiver just gets exhausted? So many of my patients, even though things are going fine at home, when they have progressive dementia, I advise them to make an application for a nursing home through the CLSC, and it's there as a backup in case they need it. If a nursing home seems to be the best option, again, nothing is perfect. We still need an advocate. It's important to be there to speak for the patient, to make sure that all of their needs are met. And to know that not all nursing homes really provide true palliative care. They might be transferring people to the hospital too freely. They might not be conscious of all of the palliative needs of the person. It is very variable, but all of the things that I've said up until now, we should be asking for in a nursing home if that's where the person we're caring for is living. So what are some medical concerns that might come up with people with advanced dementia? So this is real day-to-day life, things that will happen often. Infections, whether it's lung infections, colds, urinary tract, skin, pain, which the person might not be able to express, what we call behavioral and psychiatric symptoms, which I'll come to in a moment, eating difficulties, which can progress as the end of life approaches. I'll also get back to. So there are different ways of evaluating pain in someone who can't say, I have pain. This is one. So you can see that it looks at different ways of expressing distress, whether it's the person's breathing becomes more labored, whether they're moaning or crying out, their facial expression, their body language, whether they're upset and need to be consoled. And all of these things are given a score, and that score can tell you the presence or degree of pain in that person, and you can intervene accordingly. Behavioral and psychiatric symptoms, that can be biologic. It can be caused by lack of understanding of what's happening. Typically, someone is in a nursing home and a PAB comes along and wants to give them a shower. Why is this stranger undressing me? Why is this water touching me? That could be very distressing for the patient. many other situations where the person doesn't understand why they're in a situation, or there's too much stimulation, too much noise. So the first approach is what we call non-pharmacologic. It means that we try everything besides medication before we go on to medication. So it means approach the person with calm. And it's always good for the person with dementia to approach them with calm. If they're upset, speak to them calmly. Look for the source of distress. Sometimes it's obvious, sometimes it's not obvious. Do they have pain? Are they constipated? Do they need to go to the bathroom? Is there something else? Are they uncomfortable? Is there someone who was harsh to them? Is there an event that they don't understand? Is there too much noise? Are there too many people talking? It can be many, many different things. Often distraction works. One of my jokes in my clinic is that the good side of memory loss is that you don't remember that you were upset 2 minutes ago. And so distraction, redirecting to some more pleasant thought, some more pleasant interaction can sometimes help. And other soothing interventions like music, like odors that are pleasant to the person. Many, many things have been tried and can be effective. Then pharmacologic, I won't go into in detail, but with caution. We do use medications, very low doses, unbelievably low doses sometimes. It can be effective, and we reassess often the need for the medication and stop it if it's not needed. Eating difficulties can be an ongoing problem, especially as the dementia advances. So the first question is it really caused by the dementia? Is there something else? Is there a tooth problem? Is there dry mouth? Is the person depressed? Do they have an infection in their mouth? Is there something else going on? There are professionals who are expert in evaluating swallowing. Occupational therapists or nutritionists can do this. They look at how the person is able to actually handle the food in their mouth and send it into their esophagus and into their stomach, which can sometimes get lost as dementia advances. And then what we call conservative measures. So to still be able to feed the person by adapting to their needs. So perhaps softening the food, so mincing or pureeing meat, for example, so the texture is easier to handle. Thickening liquids. Surprisingly, one of the hardest things to swallow is water, because you have to keep it into a kind of bolus and send it into your esophagus without it going into your lungs. And so people who cannot handle liquids, we put something into the liquid that makes it like a gelatin-like consistency. They still get their liquid, but in another form. Finger foods, if they have trouble with utensils, smaller portions, favored foods, adaptive utensils. There are many ways of making eating easier for people who have trouble eating. Nutritional supplements can be good, either the liquids like Boost or Ensure, or there are protein powders that you can put into meat, into any kind of food if people have trouble getting enough protein. The question of tube feeding. Generally, in the geriatric milieu, we are not in favor of tube feeding for advanced dementia. Now, this is not something that we can do a real clinical trial of, tube feed half the patients and don't tube feed the other half. But there's no evidence that it has health benefits. And it means losing the physical act of eating and drinking, which is important to most people, even with advanced dementia. And it also can have side effects. The tube can cause problems. And above all, if someone has dementia and doesn't understand why there's this tube in their body that they didn't have before, they might want to pull it out. And if they want to pull it out, they can harm themselves. And it might be necessary to actually attach their hands so they can't pull it out. And that can be very, very distressing for someone who doesn't understand the purpose of that intervention and cannot use their hands as they would normally. So this brings us to hand feeding, which is a very good alternative to tube feeding. Obviously, it's more intensive, but it's much more human. So then the goal, this is as the end of life approaches in dementia, short term or long term. So our goal is not necessarily to provide a certain number of calories, but to feed the person, give them to drink to the extent that it's enjoyable to them, that makes them feel satiated and not thirsty. And we're talking about comfort as opposed to some kind of rule of caloric intake. So the benefits are the pleasure of tasting food, the interaction with the person who's helping the person eat. So if they can't hold the spoon, actually taking the spoon and feeding them. As you can imagine, it's labor intensive. It has to be done slowly. And there are many things that can be done improve the success, to make sure there are not too many distractions, that the person is redirected constantly to the food that's being offered to them, positioning, scheduling, many things to improve the success of hand feeding. Another question of medical care is what we call in geriatrics deprescribing. So people over time, especially if they have more than one doctor, might accumulate a long list of medications. And so we need to be continually reassessing which ones they really need, which ones they might not need, and what interactions there might be between the medications. Every medication has potential side effects, and they can contribute to each other's side effects. So, for example, if a medication makes you a little bit more drowsy or sedated, like sleeping pills or anxiety medication, it can make people more confused. It can make them fall. There are other medications can make people fall. And the more frail you are, the more you're susceptible to these side effects of medications. So we're always needing to optimize the medications that people are on. Polypharmacy just means too many pills. Drug interactions, I mentioned, can have difficulty swallowing pills. If we have trouble with food, imagine swallowing a big pill. And the pertinence of different treatments becomes changed. So if you're 95 and frail with advanced dementia, we're not concerned anymore about long-term prevention. We're thinking about short-term well-being and comfort. And again, if we stop medications, it's not because we don't care about this person's health. It's because our goals have changed as the person's condition has changed. So now we've come to death and dying. We're getting close to the end. So stage 7 dementia, I didn't really go through the stages, but it's 1 to 7. So 7 is when the person has severe dementia, severe impairment of function. So before stage 7, someone with dementia can die from all of the same things that anybody else can die from: heart, stroke, infection, cancer, whatever. At stage 7 dementia, the person might die from the dementia itself or from its complications. So typically pneumonia related to aspiration, so not being able to adequately swallow not only food and drink, but even one's own saliva can go into the lungs, cause pneumonia. Cachexia, which means malnutrition, dehydration. So progressively, as the person's ability to protect their lungs, to nourish and hydrate themselves adequately, even with all of the support that we provide, they could die from that complication of the dementia. If not, they will eventually die from the dementia itself, which, as we mentioned at the beginning, is a terminal disease. So at each crossroads, as we get to this stage, we're involved in shared decision making. So between the family caregiver, proxy decision maker, and the healthcare providers, the doctor, whatever nursing personnel is involved, whether it's at home or in a nursing home. So how intensely to intervene, when to transfer to hospital. As you can imagine, when someone has advanced dementia, being in an emergency room is a very, very stressful event. So we might avoid it if there's another way of solving the problem. If we can treat the pneumonia with pills instead of going to the hospital for intravenous, for example, there may always be reasons to transfer to hospital. Typically in nursing homes, if someone fractures their hip, for example, if you don't fix it, they will not walk again and they will deteriorate. So we might want to fix someone's hip even if they have advanced dementia, and that which requires a hospitalization, which might be brief. So these decisions need to be made, keep taking into account all of those issues that we've discussed up until now at each crossroads as the end approaches. Palliative care always trying to promote comfort, to promote well-being, to promote good interactions, caring, and all of the good things that we want to provide to our family members with dementia. Grief. As we get to the end of this presentation, the Alzheimer's Society calls grief the constant yet hidden companion of dementia. So this is even before the person dies. The caregiver, whether it's a child or a spouse or another family member, already starts to grieve because the person has changed, is not the same. You feel bereaved from who they were before. They're still there, they're still alive, they're still the same person. They are and are not the same person. So it's hard to mourn fully because they're still alive, but there is a certain mourning there. Another term that we see is ambiguous loss and grief. So we haven't lost the person, but we've lost dreams, plans for the future. We've lost a confidant, a partner, shared roles and responsibilities, the progressive losses in the life of the person with the dementia. And closure is not possible because the grief is there, but the person is still alive. We're still providing care to that person. And so it's an ongoing grief, along with many moments of happiness and pleasure, which are also part of it, but the grieving is there. And then after the loved one dies, some people find that they've done all of their grieving. They don't have strong feelings when the person dies. Others do experience the same grief as with any other death: numbness, denial, shock, pain. Some people feel relief, especially if they were very invested in the care of that person. Then they might feel guilty because they feel relief. They might feel isolated. This person was their constant companion over a number of years. They might find a loss of purpose if their life revolved more and more around the care of that person. All of these things need to be addressed, need to be worked out by support within the family, with professionals if necessary. These are all important things. So we've come to the end. I hope I've tried to guide you through. It's not all bad times. There are many, many good times where we're trying to be there for the well-being of our people right up till the end, as in any kind of palliative care. I've worked with people with dementia for more than 30 years. I derive great joy from my work, from being with my patients, from being with their family members who are so exemplary to me, and who often derive great joys and wonderful moments from providing this care and this comfort to their family member with dementia. Thank you.
Dr. Ferrier, thank you so much for, I have to say, probably one of the most important McGill Cares webcasts that I've done to date. Really quite emotional because as I'm watching it, I'm just reliving my final journey with my mother, and I'm reliving everything that I did not know. And I find this such an important webcast. As difficult as the topic is, I wish I were prepared. Not only was I not prepared for the journey of dementia as a whole, but nobody ever prepared me for what to expect at her end of life and all these important decisions that I would have to make. And, you brought up the form where we have to make the decision about what level of care to offer once our loved one is in a long-term care facility, that, resuscitate, do not resuscitate. And I will never forget that overwhelming sense of responsibility and decision that I had to make on behalf of this person whom I love so much. And, you make so many important points. I mean, I've taken so many notes, and I just wanted to talk about a few of them with you. And I'd like to begin by, having a plan A, but then you need a plan B, especially during a time of COVID. I think for most people, their intention is to keep their loved one at home as long as possible, but that's not always the case. And people feel such a tremendous amount of guilt for having to make the decision to transition to a residence. Maybe you could just talk a bit more about that.
Yeah, that is true. And I think that it's important that anybody who's having to make that kind of decision have a lot of support from their healthcare providers, from the family doctor, from whoever else is involved through the CLSC. And you're not abandoning the person when you transition them to a nursing home. You're just putting certain tasks into the hands of other people, but you're still present. And I think I've made that clear, that it's important to be still present, and people want to be still present, and to work with the team in the nursing home. Of course, COVID brought into I didn't talk about that, but it brings a whole other perspective, because we had such terrible experiences in some CHSLDs in Quebec and in other places. Hopefully, we will learn from this, and that will not be the case in the future. But I'm still grieving what happened to so many people in the early months of COVID, and I know many people who made that terrible decision to move their parent to a nursing home and then could not visit them, and so on and so forth. Was just a terrible thing. The family presence is absolutely essential for people in nursing homes.
I think you really made it also clear that as this disease progresses, the person really does lose their ability to represent themselves, to communicate. And so the role of the family member becomes that of a true advocate, and people may hear the word advocate and say, what does that mean? But essentially that means you become their voice. You have to assume all the responsibility and decision-making on their behalf. And, you point out about how, challenging behaviors could start to occur, but you have, people, like whether it's staff in the nursing homes or the family, you really have to become a detective because they can't express what they're going on. So you have to really look at and physically try to figure out what is going on.
Like with the child, like with a very young child. And as I said earlier, we accept these things from children. We don't always accept them from older people, and it's important that they deserve absolutely the same respect. But it doesn't mean that we just allow the challenging behaviors to carry on. We try to find out what's behind them, and if we can't do anything else, we intervene for them. But I didn't mention the responsibility that some people feel at having to make these decisions. But I think it's important to remember that if you're in your situation, it was your mother, you know your mother well, you've known her all your life, you know how she feels about things, even if she's never told you anything about how she would feel about certain care decisions, you probably have a relatively good idea. And so it's important to feel confident in that decision making, and to not feel guilty if you make a decision to limit care, especially when it actually will be more beneficial to her to limit care than to carry out more intensive interventions.
I work with so many family members now. And, yesterday I was having a conversation with one of them, and a woman whose husband recently went into a long-term care facility just because it became too physically demanding for her to care for him at home. And, she felt that guilt. Yeah. And I said to her, but you have permission to also live, and you have permission to take care of yourself, because your role as a care partner does not end just because he's going into a residence. You will continue advocating for him. You will continue managing his care. You will, by him being in another place, he'll be perhaps provided with a greater quality of care. But you must continue to take as best care as possible of yourself so that you can continue to take care of him. And that's the part that I didn't see. I just was consumed with guilt and consumed with anger. And I didn't realize that I had reached the point where I was doing the best that I can, but it still wasn't good enough because it was me against this illness, and you can't win against dementia. And anyways, I just find this whole topic so unbelievably important. I feel very, again, emotional today because, I was with my mother until the very end. I actually accompanied both my parents until the end. My father did not have dementia, but I was with him until the end. I was with my mother until the end. And when you talked about the grief portion, I lost both of my parents. I witnessed their death, but there was no one there to support me. The healthcare system, or there was nobody there to pick me up. It's kind of like society says, all right, well, just brush it off now and get on. And there's a real significant impact of the grief, and especially with dementia, because you're mourning the person for so many years, and it takes time to recover from this grief.
Absolutely. And the first source of support is the family and friends and so on. But sometimes it's more than they can help. So then we do need to reach out. If nothing's offered, we can ask for it. And we don't always know that we can ask for it, but we can ask for it. And there are experts in grief counseling and so on and so forth. We have to reach out to those people and get the support that we need.
Well, Dr. Ferrier, thank you so much for this absolutely so important webcast today. And you have very graciously offered to have your slides available to our viewers on our resources section at mcgill.ca/dementia. So thank you so much for being with us today.
It was a pleasure. Thank you for inviting me.
So this webcast is an initiative of the McGill Dementia Education Program, which is funded by private donations. I would like to sincerely thank the Zeller Family Foundation for supporting today's webcast. If you would like to make a contribution to our program or for more information, please visit us at mcgill.ca/dementia. And if you would like to be aware or notified of upcoming episodes of McGill Cares and other important programs that we are offering, please email us at dementia@mcgill.ca. Thank you for watching.